Welcome to Colorectal Surgery Podcast. Because every colon tells a story, and every story matters.
Welcome back to the deep dive. So you sent us this clinical review. It's on a topic that seems, well, historically a bit complicated, but maybe getting clearer now. Rectal neuroendocrine tumors, or RNETs.
That's right, RNETs.
And our mission today, basically, is to take this technical stuff and, turn it into a clear roadmap, focusing on prognosis, diagnosis, and what seems like maybe the most critical factor.
Yeah, exactly. And it's important because while neuroendocrine tumors, NETs overall, they're quite rare. The incidence is something like 7 per 100,000 people.
Okay.
But the GI tract, that accounts for over half of all NETs. And within those, rectal NETs are actually a pretty big chunk, maybe 20% of all the GI ones.
Huh. So even though the overall number is small, maybe 1 per 100,000 for RNET specifically, they pop up relatively often within that GI group.
They do. They're significant. Clinicians encounter them.
Okay, so let's rewind a bit, because you mentioned complicated history, and the confusion seems to start way back, like over a century ago.
Yeah, you got to go back to 1907. German pathologist Siegfried Oberndorfer. He's the one who first looked at these things under the microscope.
And he gave them that name.
Carcinoid, which means carcinoma-like.
Carcinoma-like, okay.
And that name, it just perfectly captures the dilemma they had back then. Oberndorfer looked at the cells, how they were dividing, and he was right. He said they look malignant microscopically.
So under the scope, they look like cancer cells, like bad news.
Exactly. But then, crucially, he watched the patients over time. He looked at the clinical outcomes, and he noted they behave likely benign.
Wait, malignant looking but benign acting? That sounds confusing.
Totally confusing. The way they actually progressed in patients was way slower, more indolent than the aggressive cancers they looked like. And back then, early 20th century pathology, they just didn't have the tools to square that circle.
That contradiction, malignant potential versus this benign behavior, and that confusion stuck around for ages, right? Led to all sorts of naming issues.
It did. So fast forward to now, we need to be clear on the language we use today.
Right. What should we be calling them?
Okay, so carcinoid tumor, that historical term from Oberndorfer. We now consider that basically synonymous with an indolent NET, or more specifically, a well-differentiated neuroendocrine tumor.
Okay, well-differentiated.
Yeah, and that helps separate these, slow-growing, usually manageable ones from the really aggressive, high-grade neuroendocrine carcinomas. Very different beast.
Got it. Okay, let's get straight to the good news then, the prognosis. Because if you're listening and you get this diagnosis, this is probably the first thing you want to hear.
Absolutely. And it's significant. RNETs have the best prognosis of all tumors in the entire GI NET family.
The best, wow.
Yeah. The 5-year survival rate is consistently up there around 80% to 90%.
80 to 90%? That's remarkably high.
It is. And it reflects that they are usually slow-growing and often caught really early.
Is that high survival rate just because they're caught early, or is there something about the tumor itself, its biology?
It's kind of both. Biologically, they often are just indolent, low grade.
Mm-hmm.
Demographically, the average age at diagnosis is around 56, slightly more common in men. But clinically, yeah, their location in the rectum means they often get picked up during routine screening.
Ah, okay. So found during routine checks. That suggests most people aren't actually having obvious symptoms.
Exactly. That's a key point. They are overwhelmingly incidental findings. Someone goes in for routine colonoscopy or sigmoidoscopy, and there it is.
Okay.
80% of RNETs are found when they're still small, like less than a centimeter, and just in that surface layer, the submucosa. That's T1 stage clinically.
And if symptoms do show up?
Usually pretty vague. Maybe a little bit of blood in the stool, that's hematochezia, or maybe some pressure, tenesmus, or just a change in bowel habits. Nothing dramatic usually.
Okay, before we go deeper, we absolutely have to address the carcinoid syndrome thing, because you hear neuroendocrine tumor and bam, your mind jumps to the flushing, the terrible diarrhea, maybe wheezing.
Yes, critical point to debunk. That syndrome, while it's definitely a hallmark of some NETs, like those starting in the small bowel, you should not really associate it with a rectal NET diagnosis. It is incredibly rare in RNETs, like maybe 1% of cases, if that.
Only 1%. Why so low?
It comes down to the biology, the specific cell type these rectal tumors usually arise from.
Okay, let's dive into that biology then. You're saying the low syndrome rate isn't just luck, it's sort of programmed in. So first off, what do they even look like during that endoscopy?
Well, often they just look like a smooth, round little bump, polypoid, like lots of benign things.
Okay.
But here's the interesting visual clue. They sometimes have this yellowish discoloration.
Yellow. Inside the rectum, that sounds pretty distinct.
You can be, yeah. And it's thought to be because of all the neurosecretory granules packed inside the cells. And those granules contain the hormones. It also means they light up with specific stains in the lab.
Ah, the biomarkers.
Exactly. The key ones we look for with immunochemistry are chromogranin A, or CGA, that's positive in about 80% of our nets.
Yeah.
Another one called synactophysin. These confirm the neuroendocrine nature.
Okay, so they are neuroendocrine cells, they've got the granules, they're probably making hormones. But why no carcinoid syndrome?
Because they're usually making the wrong hormones for that syndrome.
Wrong hormone.
Yeah. The classic carcinoid syndrome, the flushing, the diarrhea, that's driven by massive amounts of serotonin. And serotonin is typically made by a specific cell type called enterochromaffin cells, or EC cells.
And our nets aren't usually made of EC cells.
Correct. The vast majority, maybe 80% of our nets, they arise from a different neuroendocrine cell type called the L cell.
L cells. Okay. And what do L cells make instead of serotonin?
L cells primarily secrete hormones like GLP-1, glucagon-like peptide-1, and peptide YY.
Ah, GLP-1, like the diabetes and weight loss drug target.
Exactly. Same hormone. It regulates appetite, insulin secretion. Peptide YY also involved in satiety. So biologically active hormones, yes, but they don't cause those dramatic systemic serotonin effects, the flushing, the gut issues that define the carcinoid syndrome.
So it's basically the wrong cell type and the wrong location to cause that specific syndrome.
Pretty much. That's the core biological reason this syndrome is so rare with our nets.
That makes perfect sense. Okay, so we've got these usually small, incidentally found tumors, great prognosis, rarely cause the scary syndrome. Now let's shift to risk. How do doctors figure out which ones are the super low-risk ones versus the few that might need, bigger surgery or closer watching?
Right. There's a checklist of factors we look at, things that suggest a poorer prognosis.
Okay, what's on the list?
Evidence of metastasis, obviously. How deep the tumor has invaded into the rectal wall, we call that T stage, so T2 or deeper is worse. If the surgeon couldn't get it all out cleanly, that's an incomplete or R1 resection margin. The grade, meaning how aggressive the cells look, poorly differentiated is bad, if it's not from an L cell origin. And a really important one, lymphovascular invasion, or LVI.
LVI, let's quickly break that down. What is it and why is it such a big deal?
LVI means that under the microscope, you can actually see tumor cells that have broken into the tiny blood vessels or lymphatic channels right near the tumor.
So they've found an escape route.
Essentially, yes. They've gained access to the body's transport systems. It's a major red flag for potential spread for metastasis.
And the resection margin, you said R1 is incomplete?
Yeah. R0 resection means they got the whole tumor out with clean edges, no cancer cells left at the margin. R1 means there were microscopic bits left behind. That definitely changes the game for follow-up.
Okay, so all those factors matter. But the review you sent was really clear. There's one factor that kind of overshadows the others in terms of guiding what happens next.
Absolutely. Without a doubt, the single biggest factor driving the management plan, the staging needed, and ultimately the prognosis is size, tumor size.
Okay.
It dictates almost everything moving forward, primarily because it correlates so directly with the risk of the tumor spreading to nearby lymph nodes.
Okay, this feels like the core of it. Let's walk through that risk based on the size cutoffs.
Right. So remember those 80% found early, usually small. If the tumor is less than 1 centimeter, that's 10 millimeters.
Okay, pretty small.
The risk of it having already spread to lymph nodes is less than 2%, tiny, almost negligible.
Less than 2%, which explains why those can often just be removed locally, right? Like a complex polypectomy.
Exactly. Simple local excision is often enough. But now, watch what happens. If the tumor size is between 1 and 2 centimeters, that lymph node metastasis risk jumps. Suddenly it's in the range of 10% to 15%.
Wow, okay. From under 2% to potentially 15%, that's a big leap for just a few millimeters difference.
It's a significant jump, yeah.
Yeah.
A 5 to 7-fold increase in risk.
Yeah.
But then the next step, if the tumor is larger than 2 centimeters,
What happens then?
the risk just skyrockets. Now you're looking at a 60% to 80% chance of lymph node metastasis.
Wait, hang on. 60 to 80%. Let's just pause on that.
Yeah.
You go from less than 2% risk acting benignly, like Obernorfer said, to potentially an 80% risk of spread just because it grew maybe another 11 millimeters past that first centimeter mark?
That's it.
That's not a curve. That's That's like falling off a cliff, biologically speaking.
It really is. That size threshold, especially crossing the 1 centimeter and then the 2 centimeter mark, is the point where the tumor stops behaving benignly and starts showing its true malignant potential. Below 1 centimeter, it fits Oberndorfer's old observation. Above 2 centimeters, it's clearly acting like a serious malignancy needing much more aggressive treatment. Size is the absolute key here.
And this size thing connects directly to that T staging you mentioned, the depth of invasion.
It does. Remember, most RNETs, the 80%, are T1 just in that submucosal layer. But once they grow bigger than 1 centimeter, they're statistically much more likely to have pushed deeper through the submucosa into the main muscle wall of the rectum. That's T2 staging.
And being T2 is bad in itself, even separate from the lymph node risk.
Yes, T2 invasion is another major poor prognostic factor on its own.
So, okay, after the initial biopsy or maybe a simple removal, the whole diagnostic puzzle boils down to finding out the true size and depth and whether it's gotten into lymph nodes.
Precisely. Which leads us to the next crucial tool, endoscopic ultrasonography, or EUS.
EUS. Why is that so important here?
Because EUS gives us this incredibly detailed high-resolution picture of the actual layers of the rectal wall, right where the tumor is.
Better than a regular ultrasound or a CT scan?
Much better for this specific question. The EUS probe is right there, inside the rectum, next to the lesion. It can accurately see how deep the tumor goes. Is it T1, just in the submucosa, or T2, into the muscle? And it can also get a good look at the nearby perirectal lymph nodes, see if they look enlarged or suspicious.
And you'd consider doing an EUS mainly when the tumor is?
Definitely if the size is thought to be greater than 1 centimeter, based on the initial endoscopy or biopsy, because that's the point where the risk jumps. And knowing the exact T stage and nodal status becomes critical for deciding treatment.
What are they looking for on the EUS image itself?
Typically, an RNET shows up as a smooth-edged, distinct mass that looks darker than the surrounding tissue. We call that hypoechoic. Ideally, you want to see it clearly confined within that submucosal layer, T1. If the EUS shows it pushing into the deeper muscle layer, that's T2, and that often means a simple local excision isn't enough. You need a bigger surgery.
Like an oncologic resection, removing lymph nodes too?
Potentially, yes,
Yeah.
especially if the tumor is large or EUS shows suspicious nodes.
Okay. Now, what if the EUS confirms it's big? Or maybe the initial biopsy showed it was a higher grade, like grade 2 or 3. That's when you need to look further afield, right? Check for distance spread.
Exactly. That's when you escalate to systemic imaging.
What triggers needing those full-body scans?
The main criteria are an RNET size, definitely measured as greater than 1 centimeter, or if it's any grade 2 or grade 3 tumor, regardless of size, or of course if the patient has any symptoms that make you worry about metastasis somewhere else.
And what scans are we talking about?
Usually a CT scan or an MRI of the abdomen and pelvis, and often a specialized PIC scan called a PET-CP dotatate scan.
Dotatate. What's special about that one?
NET cells, including RNETs, often have lots of receptors on their surface for a hormone called somatostatin. The dotatate scan uses a tracer that binds to those receptors so it can light up NET deposits anywhere in the body with high sensitivity.
Makes sense. And if it has spread, where does it most often go?
The liver is the #1 spot. About 58% of distant metastases are found there. But we also check the bones, lungs, other areas.
Okay, this brings us to maybe the most practical summary for someone listening. How does all this risk stuff, size, grade, LVI, staging, translate into what actually happens next? The management, the follow-up. How different is it for low risk versus high risk?
Oh, the difference is massive. It's night and day, really, both clinically and for the patient's life.
Okay, lay it out. Low risk first.
Okay, low risk. Let's say you have a tumor that's 10 millimeters or smaller. It's grade 1. Surgeon got it all out cleanly, R0 resection, and there's absolutely no lymphovascular invasion, LVI negative.
So the best case scenario, basically.
The best case. For those patients, the current consensus guidelines say no follow-up is required.
No follow-up, like you're just done.
You're done. You're considered cured. You go back to normal life.
Wow, that must be incredible relief.
It's huge. But now, flip to the other side, the high-risk scenario. Maybe the RNET was bigger than 10 millimeters, or LVI was present, or it was a grade 2 or grade 3 tumor.
Okay, what does life look like then?
Then you are signing up for intense surveillance, typically lasting for 5 years.
5 years of?
We're talking an MRI scan, usually of the abdomen to check the liver, every 6 months for 5 years. You'll also need a sigmoidoscopy, looking back into the rectum, once a year for 5 years. Plus, you'd likely get that PET-CT dotatate scan initially, and then again at the 1-year mark to check systemically.
Whoa, every 6 months an MRI, yearly scopes, PET scans for 5 years. That's a heavy burden.
It's a massive commitment, logistically, psychologically, financially. The contrast between no follow-up needed and 5 years of intense structured monitoring is stark.
And that huge difference hinges almost entirely on whether that tumor nudged over the 10 millimeter mark or showed those little cells sneaking into vessels.
That's basically it. It just highlights how absolutely critical finding these things early really is. Catching that RNet when it's still T1 and well under a centimeter means the vast majority of people can genuinely put it behind them.
So we started this whole thing talking about Oberndorfer back in 1907, right?
Yeah.
His confusion. Looks malignant, acts benign. And the big takeaway seems to be that for most people, RNets do act pretty indolently. They are manageable. But there's this incredibly sharp dividing line. The moment that tumor crosses the 1 centimeter size threshold, everything changes.
Everything. The complexity, the surgery needed, the risk of spread, it just leaps up immediately and dramatically. That size measurement is the physical reality that finally lets us resolve Oberndorfer's old paradox.
It's like the technology being able to measure size and depth accurately with EUS. The sophisticated grading it finally gave us the tool to separate the benign behavior from the underlying malignant potential. And it turns out, for RNets, that separation happens right around 1 centimeter.
Exactly, which kind of leads to a final thought, doesn't it?
Yeah.
Well, thinking about this journey with RNets, it makes you wonder, doesn't it? What other conditions out there that we currently think of as benign or maybe just indolent, could they also be hiding some critical measurable threshold, like a size or a depth or some biomarker level, that if it gets crossed, it suddenly demands a completely different, maybe much more urgent approach to care?
Are there other ticking time bombs disguised as benign conditions, just waiting for us to find the right ruler? That is definitely food for thought. Thanks for breaking that all down.
My pleasure.
And thank you for joining us on the Deep Dive.